All right, hi. So this video is going to tackle the endocrine system, okay? So as we're preparing for the AANP exam to become nurse practitioners, baby, nurse practitioners, come on, we can do this, we can do this. As we're doing that, we're gonna remain hydrated, keep your water, and keep your electrolytes going, and Doritos. Section is about PTH, calcitonin, and calcium. What's the relationship between these three things, okay? So parathyroid hormone increase the calcium in your blood. So when someone has hyperparathyroidism, you need to look for signs of hypercalcemia in the blood. Okay, because PTH increased the calcium in the blood. And then calcitonin decreased the calcium in the blood. And the way to remember that is the calcitonin puts the calcium back into my bone-in. Okay? Don't tell me why I'm saying bone-in. Listen, we all know that I'm saying bone-in because I want it to rhyme with calcitonin, okay? What that means is there will be less calcium in the blood. More calcium in the bone, less calcium in the blood. Moving along, the normal calcium level is 8 to 10. Just remember this number, 8 to 10. So I read multiple review books where they had different numbers, 9 to 12.5 and 8.7 to 11. Who cares, man? Who cares? Who's gonna sit there and remember all that? We just have to remember the average, okay? 8 to 10. Or 9 to 11, something, I don't know, 9 to 10. Just remember something and keep it in your head and that's it. Don't get distracted by other crazy numbers. 8 to 10. Let's see, if the patient has high calcium or low calcium, what do? You order PTH levels, okay? Because this is how we're gonna check for parathyroid gland to see how it's doing, because the PTH, the parathyroid gland, directly affects calcium levels, okay? Calcium blood levels are used to diagnose PTH disease, okay? So when you check your patient's lab work, your calcium, if it's high or low, the next step has to be you're thinking PTH, okay? Biophosphates is used to treat secondary hyperparathyroidism, and it's used to treat osteoporosis as well, okay? And then sign of hypocalcemia is chavostic, okay? That means low calcium. I'm not gonna sit here and explain all these signs. You can look that up. You can Google all these things. Here, we're just trying to give it small notes, small nuggets of information to prepare you guys for the AANP board certification so you can become nurse practitioners. All right, the next section is about calcium and phosphorus. So high calcium leads to low phosphorus. So calcium and phosphorus are seesaw, okay? Calcium and phosphorus are seesaw. When one increase, the other will decrease. Calcium phosphorus, calcium phosphorus. Remember that. After that, we're going to talk about TSH, T3, and T4, okay? Your beloved thyroid, way more common than you think. So the normal TSH, we're going to start off with knowing our normal TSH level. It's 0.5 to 5, okay? This is way to remember, 0.5 to 5, okay? And you use TSH to determine the treatment regimen for hypothyroidism or hyperthyroidism, okay? What you use to treat your patients is the TSH level. It's not T3, it's not T4, okay? Now, if the TSH level is high, that's when you increase the dose of Synthroid, okay? Remember that, TSH high, you increase the dose of Synthroid. When patient is on Synthroid, you only use TSH to determine when to change the dose, okay? In the test, they will try to trick you. They'll say, oh, your patient is on Synthroid, and it's time to check the lab work. What are you gonna order for your patient? TSH, baby. You're gonna order TSH, okay? They're gonna trick you. They're gonna say, oh, You also need to look at your T3 and T4 so you can see how you're going to change the dose. No, ma'am. No, ma'am. The only hormone you're going to use to change your synthroid or levothyroxine dosage is your TSH, okay? If it's too high, you need to increase your synthroid dose. Also, do not change the dose until you wait 6 to 8 weeks. Thyroid hormones take time. You can't just expect it to work like that, you know? So you gotta wait. Don't flip-flop doses until you wait 6 to 8 weeks, okay? Synthroid takes 6 to 8 weeks to work, okay? Monitoring now, you monitor TSH level every 6 to 8 weeks, okay? Until TSH is normal. Once TSH is normal, then you monitor TSH level every 6 to 12 months, okay? So keep that in mind. I have all these highlighted in my blog. I like these because it kind of helps me remember all the numbers together. Synthroid starting dose is 25 microgram, okay? Not milligram, it's microgram. But with elderly, their starting dose has to be 12.5 microgram. Okay, why? Because you got to start slow with our elderly population. You got to crush it with your teeth and take it on empty stomach. Okay? Next, we're going to talk about hyperthyroidism. So hyperthyroidism, now what are the diagnoses of it? It's TSH will be less than 0.5 and free T4 will be high and free T3 will be high. Okay? So if the TSH is less than 0.5 and you notice that, you're like, oh, TSH is low. What's the next step? You gotta order T3 and free T4. Okay? So if elevated, then you order antibodies. That's how you rule out Graves' disease. Okay? So remember that process of diagnosing. If the TSH is less than 0.5, the next step you have to order T3 and free T4. If both of these are also high, and then you order antibodies. That's how you look for Graves' disease. That's how you give a diagnosis of Graves' disease. So just because someone's TSH is low doesn't make them have Graves' disease. You gotta go through the systematic diagnosis and algorithm. Signs and symptoms of hyperthyroidism. You eat whatever you want, you don't gain weight. You have weight loss all the time, you have palpitation, you have anxiety, you have lid lag, and exophthalmos. It's the eyes that are very prominent in the face. In hyperthyroidism, you gotta rule out thyroid cancer by ordering thyroid ultrasound. It will show you hot spots and cold spots. The hot spots are benign and the cold spots are possible cancer. How do you treat it? Medications for hyperthyroidism is PTU and methimazole, aka tapazole, and RAIU, which is radioactive iodine to shrink the thyroid gland, okay? So these are your 3 treatments for hyperthyroidism. The first one is PTU, the second one is tapazole, and the third one is RAIU, radioactive iodine, okay? These meds will cause you to have hypothyroidism and be on Synthroid for life. Does that make sense? You're treating hyperthyroidism, but because you're giving them all these medications that lowers the thyroid, the patient's going to end up with hypothyroidism. And then you're going to need Synthroid, you're going to need levothyroxine for the rest of your life because you've taken these meds that kind of lower your thyroid hormones. Moving along, radioactive iodine is an absolute contraindication if a patient is pregnant or breastfeeding. Okay, do not do radioactive iodine for women who are pregnant or breastfeeding. And if hyperthyroidism is not treated, you're going to end up with thyroid storm. So there are a mnemonic for you. There's a mnemonic coming up, guys. It's LAF. LAF is the signs of thyroid storm. So the first one is L. L is the change of LOC, change of level of consciousness. A is for abdominal pain, and F is for fever. Okay, LAF. these are signs of thyroid storm. You got to send your patient to the emergency department. Lithium and amiodarone are two medications that can cause hyperthyroidism. Hyperthyroidism can cause high PTH, parathyroid hormones, which means what? What's PTH? What does that do to the calcium? High calcium means more calcium in the blood and less calcium in the bone, which puts the patient at high risk of osteoporosis, because when there's not enough calcium in your bone, that's your osteoporosis right there. So patients with both osteoporosis and hyperthyroidism will need calcium supplements, okay? So when you see your patients having hyperthyroidism and osteoporosis, put them on calcium supplements. And then we're gonna move along to hypothyroidism. So the diagnosis for hypothyroidism is the TSH has to be more than 0.5, and your free T4 has to be low, and your T3 are normal, okay? Remember these three things. They're different from the hyperthyroidism. Remember, hyperthyroidism, that highlighted area that I have in there in green, the TSH is less than 0.5. Free T4 is high. Free T3 is high. That's hyperthyroidism. Hypothyroidism, on the other hand, TSH is more than 0.5. Free T4 is low, but T3 is normal. It's not low, it's normal. If TSH is over 5, the next step now, you don't just magically diagnose people, oh, that's it, you have that, you have that. No. If the TSH is over 5, you order TSH again with free T4, okay? If TSH is still over 5 and the free T4 is still low, that's your diagnosis of hypothyroidism. You just diagnosed someone. This is your diagnosis now. And the sign and symptoms for hypothyroidism is everything slowed down. Heart rate, weight gain, everything is slow. It's like the opposite of hyperthyroidism. So the next step now, after you diagnose someone with hypothyroidism, now you got to rule out another disease, not Graves' disease. Graves' disease is for hyperthyroidism. Now we're going to have to rule out something else. So you order TPO, which is antithyroid peroxidase and antithyroglobulin antibodies. TPOs, okay? Why do you order these things? Because now we're going to check for Hashimoto's, okay? High TPOs, that's your diagnosis of Hashimoto's. So if you do all these things, you diagnose your hypothyroidism, then you do the TPOs are high, that's your diagnosis of Hashimoto's. You only order TPOs after you already order TSH and T3 and T4 levels. Don't get ahead of yourself. They're going to try to confuse you in the test, like, oh, what do you order next? The patient has these signs and symptoms. TSH is more than 0.5. What do you do? Blah, blah, blah. No. Go in order. Follow the order. Okay? And then we move on to the subclinical hyper and hypothyroidism. Subclinical hyperthyroidism and subclinical hypothyroidism is when TSH is high or low, but the free T4 is normal. Okay, and then also the big thing about that, it's asymptomatic. There's no symptoms, okay? Do not treat subclinical hyper or hypothyroidism. Just recheck the levels in 12 months, okay? So this is also gonna pop in the test. They're gonna try to make sure you know your numbers, make sure you know how do you diagnose hyper, how do you diagnose hypo, and then how do you distinguish them from subclinical hyper and subclinical hypo. When diagnosing hyper or hypo, use both TSH and free T4. When treating hyper or hypo, use only TSH levels. Okay, so this concludes my little section here, and then I'll do another video to finish up the endocrine. But yeah, have fun, guys. Happy studying.